This is a short section. Welcome to Chapter 4, Pulmonary Hypertension. Now, pulmonary hypertension can be secondary to chronic lung fibrosis. However, a primary pulmonary hypertension is a relatively rare disorder. If the question says what's the most common cause of pulmonary hypertension, overall the most common cause of pulmonary hypertension is chronic lung disease like COPD. However, a primary pulmonary hypertension means you don't have COPD, you don't have COPD, you don't have pulmonary fibrosis, you don't have interstitial lung disease, you just get a tight pulmonary artery causing shortness of breath, and often in young women, like the same way that young women get fibromuscular dysplasia of their renal arteries. And there's overgrowth of the pulmonary artery vasculature, and that's a great answer because now we can treat that. We have endothelin-1 antagonists that can treat that. So pulmonary hypertension can occur secondary to things that make the lungs fibrotic, things that make the heart fibrotic, things that make the lung and the heart fibrotic, things that make the blood thick, like polycythemia vera makes the blood thick, and it's harder to pump it, just slower to pump it. Chronic pulmonary emboli make it harder to pump it. And pulmonary hypertension, the physical findings in all of these, a loud P2 is a sign of pulmonary hypertension, tricuspid regurgitation because the blood is flowing backwards into the heart, and a right ventricular hypertrophy, which is a heave. It actually can lift up the hand underneath the sternum. The same way that pulmonary hypertension is hypersensitivity, that lung vasculature, it also can be associated with the same hypersensitivity in the peripheral arteries as well, or Raynaud's phenomenon. Diagnostic tests start with a transthoracic echocardiogram. Now, the interesting thing is that the transthoracic echo is almost equal to the transesophageal for right ventricular things because the right ventricle is very anterior. The transesophageal is more accurate for mitral lesions because the mitral lesions are posterior. And where's your esophagus? Posterior. So for mitral things and left atrium, left posterior, but the right is anterior. That's why transthoracic echo is so good for pulmonary hypertension. That shows right ventricular hypertrophy and right atrial hypertrophy on that EKG. The diagnostic test, the most accurate thing, the most accurate way to see the pressures in there is to actually put a catheter into the pulmonary artery and actually do a right heart cath like the Swan-Ganz catheter. Now, the Swan-Ganz catheter is a device that we don't use routinely a lot, but in pulmonary hypertension, it is the standard of care to do a right heart cath. Why? Why can't we see the pulmonary hypertension on the echo? What do we need a catheter for? We see right atrial and right ventricular hypertrophy on an EKG. We see pulmonary hypertension on an echo. The transthoracic is as good as the transesophageal for right-sided things because on the anterior surface of the heart is the right ventricle. The anterior surface of the heart is the right ventricle. Why do we have to do the catheter? Because the catheter, although it is the most precise way to get the pressures, the catheter tells us who'll respond to therapy. Oh, the catheter tells us, I give you a calcium blocker, did the pressure go down? I gave you Viagra, sildenafil, tadalafil, did the pressure go down? I gave you medications, did the pressure go down? You see, treatment for primary pulmonary hypertension is very difficult. It's very difficult. And what I mean by very difficult is we are not certain who really responds. For instance, we know that pretty much everybody is going to slow their heart rate with a metoprolol, beta blocker. I don't have to do EP studies. I don't give them beta blocker. It's going to slow their heart rate. But I don't know who's going to respond to each of these pulmonary hypertension meds. And that's why I have to do echoes and look, and that's color flow Doppler. Based on whether the blood is flowing towards or away from you, makes it red and blue. But you see, the right ventricular hypertrophy. The right ventricular hypertrophy is showing tall R waves in V1, tall R waves in V1, tall R waves in V1 and V2, tall R waves in V1 and V2. Well, how do I know it's not a right bundle branch block? Because I don't see an R prime. I don't see an R and R prime. I don't see an R and R prime. Right ventricular hypertrophy. The Swan-Ganz catheter. This is one of the greatest utilities of the Swan because it helps me determine the response to therapy. Now, pulmonary hypertension is a very short chapter because you just have to know a few points. You're short of breath, but everybody in pulmonary is short of breath. You get a chest x-ray, an echocardiogram first? Yeah, but that's everybody. But what's different? The right heart cath tells you, are you going to respond to bosentan? Isn't it cool, though, that we actually know which particular receptors in that pulmonary artery that's an endothelin-1 antagonist? Bosentan, ambrisentan, bosentan, ambrisentan, or prostacyclin analogs. Now, prostacyclin, not prostaglandin, epoprostenol, treprostenol, iloprost, epoprostenol, treprostenol, iloprost. These are specific to the pulmonary artery prostacyclins. And that's precisely the kind of mechanism that would be a good fundamental correlate for step 3. Calcium channel blockers have weak efficacy, so you've got to do the right heart cath before and after. Sildenafil, you don't know what's going to happen. It's okay, we don't know whether they're going to respond. Do the right heart cath. Pulmonary hypertension makes you short of breath. Right ventricular hypertrophy is easy to see on a transthoracic echo because the right ventricle is an anterior structure, and we do the catheterization predominantly to guide therapy with the medications to see who's going to respond to endothelin antagonists, bosentan, ambrisentan, prostacyclin analogs, epoprostenol, treprostenol, iloprost. Who will respond to calcium channel blockers and who will respond to sildenafil, the phosphodiesterase medications?